Okay, so it's 2:03, so I think we may start introduction. So again, good afternoon, everyone. My name is Jan Argasiński. It is my honor to welcome you all to today's seminar on behalf of Marian Bubak, who unfortunately is unable to join us today, but he sends his warm regards. Our today's guest is Sandrine Morel from Neurocenter, Geneva University Hospitals and Neurosurgery, Department of Clinical Neurosciences, Geneva University Hospitals, and Faculty of Medicine, University of Geneva. So our guests conduct research across fundamental, translational, and clinical sciences, drawing on over 20 years of experience in basic research and 7 years in the clinical domain. She teaches at the Faculty of Medicine at the University of Geneva, co-leads PhD training module, and supervises both master's and doctoral students. Since 2015, she has been actively engaged in national and international projects focused on intracranial aneurysms. The presentation title is From Aneurysm Wall to Decision Support, Insight from the AneuX Biobank. So welcome. Please feel free to start whenever you're ready.
Thank you, Jan. So good afternoon, everyone, and thank you for the invitation to show you our work related to the AneuX Biobank. So our disease of interest is intracranial aneurysm. They are local outputting of an intracranial artery, as you can see here. They are located mainly at the level of the circle of Willis, which is a network of arteries present at the basis of the brain and allowing its perfusion. The prevalence of intracranial aneurysm is 3 to 5% of the population, and they are usually asymptomatic. But the problem associated with their presence is their rupture that can lead to subarachnoid hemorrhage, which affect well over 10,000 persons a year. This rupture can lead to a lot of disability or even to the death of the patient. Here are statistics for Switzerland. So what we can see is that in case of a rupture, in 24% of the patient, it will lead to the death of the patient. For around 15% of the patient, it will induce severe disabilities. For 40%, it will induce moderate or light disabilities, and only 24% of the patients are able to come back to a normal life. When an aneurysm is formed, it can stay stable throughout the life of the patient. It can also grow. It can be a sudden growth. It can be a progressive growth. And the growth can affect the globality of the aneurysm dome, or it can be the appearance of a small blebs or lobus. And it can also, as I mentioned previously, rupture. So when an unruptured aneurysm is diagnosed, it can be treated. There are two modalities to treat an intracranial aneurysm. It can be treated by microsurgery or by endovascular techniques. But these treatments can also induce some morbidities and also can lead to mortality. And depending on the techniques and the aneurysm location, the comorbidities of the patient, it can induce 1 to 5% of disorders after treatment. So when an unruptured aneurysm is diagnosed, the clinician has to balance the risk associated with the rupture and the risk associated with the treatment. To help in the decision, scores exist in clinics that they can use here I showed you the two main scores that can be used, so the phases score and the UIATS score. In this score, you can see that it includes factors related to the patient itself, such as ethnicity, hypertension, age, but also smoking, previous disease, comorbidities. And it includes also information linked to the aneurysm itself, such as the size, the location, and also some morphological indexes. The problem with this score is that they are not completely satisfying. So we would like to have a more reliable tool to support decision-making for a more precise and personalized medicine. So for that, we need markers of intracranial aneurysm wall instability. So in this context, we have decided to establish the AneuX Biobank, which is a biobank of human aneurysm dome. So these domes are obtained during the microsurgery when the dome is clipped to secure the aneurysm. So here you can see the clip placed at the neck of the aneurysm dome. After the dome is cut, so we keep this dome in formol, it's embedded in paraffin, and like that we can perform stainings to characterize the intracranial aneurysm dome. And for this biobank, we have an official label here in Switzerland. So what do we know about the organization of a cerebral artery and of the aneurysm wall? So here you have a picture for a normal cerebral artery in which we can find the intima composed of mainly endothelial cells, the media full of smooth muscle cells. The media and the intima are separated by the internal elastic lamina. And in the adventitia, we have some supportive tissue and fibroblasts. And one characteristic of a cerebral artery is the absence of the external elastic lamina between adventitia and media. When the aneurysm is formed, we can observe a disruption of the internal elastic lamina. There is a loss of endothelial cells covering the intraluminal part of the dome, a loss of smooth muscle cells inside the media, and the infiltration of inflammatory cells. So we have decided to investigate how is the wall of the aneurysm inside our cohort. So here are some examples of immunostainings that we did on intracranial aneurysm dome. Here, an example for endothelial cells stained in brown. So you can see here inside in the intraluminal part of the dome. Smooth muscle cells still in brown inside the media, and some inflammatory cells also stained in brown. And we have compared ruptured and unruptured samples, and we have observed that in ruptured samples, there are a lower content in endothelial cells in comparison to unruptured samples. Same type of results for the content in smooth muscle cells, so less cells inside the media. At the opposite, we observe a higher quantity of inflammatory cells inside the aneurysm wall in ruptured samples in comparison to unruptured samples. We do also some staining for the extracellular matrix composition. So in the first row, we have a staining for elastin that you can see in blue. We did also staining for collagen. So here you have total collagen in blue. And on the last row, it's a staining in which we can see collagen type 1 in red and collagen type 3 in green. We have again compared the two types of samples. For elastin, we haven't seen a clear difference between ruptured and unruptured aneurysm. But for collagen, we observed a significant reduction of collagen content in ruptured samples in comparison to unruptured samples. Johanna Frozen, a neurosurgeon in Finland, has established a classification for aneurysm wall. This classification is based on 4 grades. Grade A, it's for presence of endothelial cells and nicely aligned smooth muscle cells in the wall, so it's a quite normal arterial wall. Grade B is for a thickening of the aneurysm wall, but presence of a lot of smooth muscle cells, which are disorganized but present. In grade C, it's hypocellular wall, and grade D are very thin wall. Grade A and B are considered to be safe for the wall, and grade C and D to be more at risk of rupture. So we have classified our samples from the AneuX Biobank between these different grades, and we have observed that for ruptured samples, we found more often grade C and D, so more vulnerable wall for the rupture. So these results were in accordance with what was already published in the literature. So we considered that we can use our samples to investigate more in details the vulnerability of the aneurysm wall. When we have investigated the composition of the wall, we have also observed that the thickness of the wall can be very different between the samples. Here you have 3 typical examples. In the first one, we can see that the wall is thin, but the thickness is more or less the same throughout the aneurysm wall. In this second example, the thickness is again homogeneous, but we can observe that the thickness is higher in comparison to this one. And in this third sample, we can see that there is thick part and very thin part. So we have a wall homogeneous in terms of thickness and walls heterogeneous in terms of thickness. In a previous study performed by Kadasi and al., they investigated this difference in thickness by quantifying that based on pictures taken during the surgery. And they defined the red zone as a very thin wall and the white zone as thick wall. And they have observed differences in terms of thickness depending on the size of the aneurysm dome and also depending on the gender of the patient. So we have decided to investigate this point, but by measuring more quantitatively the thickness of the dome. So for that, we have measured the thickness on histological sections, and we have defined the thickness homogeneity or heterogeneity. So for that, we have represented here the frequency of the different thickness that we can measure. And when we have one Gaussian curve representing this thickness, it means that the thickness is uniform. When we have more than one Gaussian curve, it means that the thickness is non-uniform. And we have checked whether we found differences in terms of thickness and thickness homogeneity between our different group of patients. So as done in the paper of Kadasi, we have compared men and women. At the opposite of what they showed, we observed that the aneurysm wall of women was thicker in comparison to the aneurysm wall of men. But interestingly, we observed that in case of women, the thickness was less uniform in comparison to the aneurysm wall in men. As they showed in their study, we have observed a correlation between the size of the aneurysm dome and the thickness of the wall. And finally, when we have compared our ruptured and unruptured samples, we have observed that in ruptured samples, the thickness is less uniform in comparison to unruptured aneurysm. So meaning that the thickness of the wall is something important in terms of stability, and more particularly the homogeneity in this thickness. So it's interesting to know that, but how can we use that to help the clinician to take a decision to treat or not an aneurysm? So we have decided to investigate whether it exists a link between the thickness and the morphology of the aneurysm. In a previous study that we did in collaboration with the ZAV Institute from Zurich, Norman Juckler showed that the shape irregularity of an intracranial aneurysm lumen exhibits some diagnostic value. He tested several morphological markers based on this type of images. One interesting marker is NSI, the non-sphericity index, which is the difference between aneurysm shape and a perfect sphere. So when we investigated whether it exists a link between the thickness of the wall and the morphology of the aneurysm, we observed that when we have heterogeneity in terms of the aneurysm wall in terms of thickness, we have a shift in the NSI. So it means that we could use this NSI as marker of aneurysm wall thickness, and it can be used as marker of intracranial aneurysm wall instability. So with these different experiments that we did on our AneuX Biobank, so we analyzed the composition of the aneurysm wall, we investigated the thickness of the wall, and also we linked that to morphological indexes. So now the goal is to be able to link these different results with risk factors known for aneurysm rupture. So this is the risk factor used by the clinician. So this is the two scores that I previously showed you. So we investigated some of these risk factors in our Geneva cohort, but also in the context of the International Stroke Genetic Consortium. So in Geneva, we are in charge to collect the phenotypic data from the patient included in this consortium. So we have data coming from 14 different cohorts. And we collected first a minimum set of data being the basis of recruitment, meaning if the patient has or not an intracranial aneurysm, and if he was firstly diagnosed in the context of a rupture or in the context of an asymptomatic intracranial aneurysm. So the sex, the positive family history for the disease, hypertension, smoking, age at time of aneurysm rupture, and whether the patient has one or several aneurysms. And regarding the aneurysm, we collected the rupture status, the maximum diameter at rupture, and the aneurysm location. So I will show you some results linked to this study. So first, it's known that women are more exposed to intracranial aneurysm in comparison to men. So in this graph, we have the reference population, so the global population, in which we have more or less 50% of women, 50% of men. And we can see that in our cohort, so the ESGC cohort, we have more women in comparison to men. So our cohort is representative of what is known about this disease. When we have checked for the diagnosis of rupture, we can see that there are no difference between men and women, meaning that that women are more exposed to the risk of formation, but they are not exposed to a higher risk of rupture. In addition, when a rupture occurs, it occurs at a later age in women in comparison to men, and these ages are close to the age of menopause. In terms of size, we did not find any difference between men and women. So we have investigated the composition of the aneurysm dome between men and women. And for women, we did two separate groups depending on the age, and the age is based on the mean age at menopause. And we can observe that endothelial cells presence is different between younger women and men or older women. Endothelial cells are the first cells exposed to the blood, so it can explain the differences between men and women in terms of intracranial aneurysm formation and stability. So this is something that needs to be more investigated. Another factor that we investigated is smoking. So what we can see here is that current smokers are more exposed to the risks to have a ruptured aneurysm, which is known also. Interestingly, former smokers are less exposed to the risk of intracranial aneurysm rupture. In addition, in case of rupture, the age at rupture is lower in smokers in comparison to former smokers or to non-smokers. And also, the size at the rupture is higher in smokers in comparison to the two other groups. In terms of wall composition, what we have observed is that the aneurysm wall of smokers contain less smooth muscle cells, so inside the media, in comparison to the intracranial aneurysm wall of non-smokers. And this lower content of smooth muscle cells in unruptured aneurysm is very close to what we can observe in ruptured aneurysm, meaning that smoking affects the content in smooth muscle cells in cerebral intracranial aneurysm wall, and that this lower content can explain, at least in part, the rupture of the intracranial aneurysm. So we did separate studies. We have studies focusing on the composition of the aneurysm wall and studies focusing on risk factors for rupture. So the goal now is to combine all this data to provide reliable decision tools. So for that, in collaboration with the ZAV Institute, we have decided to move to the Bayesian network modeling, which is a model based on interrelationship between variables. So in this paper did by Matteo De Lucci, he investigated several factors relevant for the disease, such as age, the sex, the family history for intracranial aneurysm. So there are non-modifiable risk factors which are modifiable, such as hypertension and smoking, and factors characterizing the intracranial aneurysm, so multiplicity, size, and location. And based on that, he established the first Bayesian network modeling for intracranial aneurysm disease, so linked to the rupture of the aneurysm. So our goal is now to improve this model to can deliver a tool. So this is what we are now doing in the context of the Gemini project. So we are part of the work package for the population-based hemorrhagic stroke models. So here are the factors that I just show you for the Bayesian network modeling. And we are now adding data coming from our biobank. So first, we will add data regarding genetics. So thanks to our collaboration with the International Stroke Genetic Consortium, our patients have been genotyped. And in a study performed by Mark Baker in Utrecht, he showed that some polymorphism linked to hypertension and smoking can affect intracranial aneurysm disease. We will add these results to the current model. In addition, in Geneva, we have a cohort of patients affected by polycystic kidney disease. This disease is known to favor the formation and the rupture of intracranial aneurysm. We have collected some domes of of this patient. And in this zone, we have observed that there is a lower content in collagen in comparison to patients not affected by this disease, and that the aneurysm wall is thinner in this patient with kidney disease in comparison to patient without kidney disease, meaning that the aneurysm wall of this patient is more vulnerable in terms of aneurysm rupture. So we will also be able to add such data coming from the biobank to the current model. Now, regarding the aneurysm, as I said to you, we observed a link between aneurysm thickness and morphometric parameters. So, thanks to the collaboration with ZAV and SimoncCure, we will increase the number of data regarding these morphometric parameters, and we will see whether we can add that to the current model, and in addition, if these morphometric parameters could replace another parameters regarding aneurysm characteristics. Regarding this part, we also work with the University of Galway, and based on our histological investigation, they are developing biomechanical models to simulate the disease, and more particularly to model the aneurysm growth, which is known to favor aneurysm rupture. Regarding modifiable factors, one that we do not have investigated for the moment, it's treatment modalities. So we work with the University of Amsterdam and the University of Budapest, and by using our clinical images, they simulate treatments, so endovascular treatment, so coiling or flow diverter flow diverter. And so this simulation will also be added to the models to see how it influences the recovery of the patient. So for the outcomes, we will investigate several things. So presence of vasospasm linked to the rupture, delay cerebral ischemia, but also disability and mortality. And we will investigate if the mortality is linked to the aneurysm or not. And to do all of that, we will, of course, have different groups of interest. So stable aneurysm, growing aneurysm, treated aneurysm, or ruptured aneurysm. So thanks to all the data we collected in our biobank, we will add new parameters to the current Bayesian network model that we have. And with that, we hope to be able to provide a reliable tool to help decision support in case of intracranial aneurysm diagnosis. So with that, I would like to thank all my colleagues involved in this different project. So in the Geneva University Hospital, so more particularly in neurosurgery, and my colleagues in the Department of Pathology and Immunology in the University of Geneva, our collaborators in Switzerland and outside, the former foundation which granted these different works, and of course, the current Gemini project. And with that, I would like to thank you for your attention.
Okay, so thank you very much for this wonderful presentation. Now it's time for questions. So if anyone wants to ask a question, please do so. You can raise your hand in Zoom, or you can ask directly if you want. You can write on the chat. So maybe I will start. I have one question, because you mentioned that this is Bayesian framework. Yeah. So you are using. So I understand this is going to be tool that allows for individual estimations, like for individual patient prognosis. You have this already implemented, or is it work in progress?
No, it's for the moment it's not implemented. We work only with few factors for the moment, and it really needs to be we really need to add more factors. For the moment, no, it's not used.
Okay, but you tested it on like actual patients, like individually, because I know you do it like populationally, but
Yes.
individually.
No. For the moment, what is done is to compare what we obtained, the Bayesian network did for the population in Geneva, so for our cohort. And now what the next step was to test that for the multicentric data. So what is currently done to adapt the Bayesian model for multicentric data to be sure that it can be used for all cohorts and not only for Geneva. So, and it will be published soon.
Okay. Any questions? Anyone from the audience? Oh, okay. Vyosław, please go ahead.
Okay, hello, can you hear me?
Yeah.
Yes.
Okay, thank you, Sandrine, for this elegant presentation. You have done excellent work regarding wall composition, morphology, and so on. Have you studied some biomechanical properties? Because finally the rupture depends on biomechanical properties. You mentioned about some collaboration, but you didn't explain. Have you studied, what are the conditions where an aneurysm might rupture, and can we do any prediction for specific cases?
Yes. So for the moment, we didn't do ourselves some biomechanical models. It will be done by the University of Galway. So they will use our samples, and they will consider the collagen organization, the difference between the different type of collagen, and also the organization of smooth muscle cells. They will investigate the subpopulation of smooth muscle cells, and they will integrate all of that to develop biomechanical models of the disease.
Okay, thank you. You also haven't talked much about treatment. But I have a question which somehow it's a long-term question, because once I attended a wonderful talk presented by two experts. One was Jacques Morel from Rothschild Foundation, who is, of course, a world-class expert in aneurysm coiling, and another was Robert Spetzler from Barrows, who is an expert in clipping, probably the most expensive American neurosurgeon. And of course, after every talk, I had the impression only coiling, only clipping. Do you think that your work can lead to the situation that it will be possible for clinicians to decide which technique is better, coiling or clipping?
So yes, it's what it's one of our goal. It's to find the best modalities, really depending of the aneurysm. We already know that depending of the location, the techniques is not the same, but it depends also of the hospital. Some hospitals are more used with microsurgery, other with endovascular techniques. Here, for example, in Geneva, we have both, and it's a decision taken between the neurosurgeon and the endovascular clinician. And based, yes, it really depends of the location, but we really hope that with our model, we will be able to give a clear answer and to really define the best treatment modalities.
Okay, so let's say that if you decide about modality, so within modality also you plan to have some indications for neurosurgeons, for example, if they decide to do clipping, it might be single, multiple, or tandem clipping. Do you consider this kind of models to be included in your process?
You mean the different type of clipping?
Yeah, different techniques of clipping.
Oh, okay.
Because of course they depend on the morphology. Not
Yeah.
only, yeah.
Yes, for the moment, it's true that we did not make distinction between the different techniques of microsurgery. We just keep microsurgery as one entity.
Yeah, and you show a scale from, I think, 0 to 4, depending on location. One point was that you say ACA is 0, I think PCOM 4. Posterior. Posterior doesn't include basilar artery as well, because VA aneurysm are very popular.
Yes, in this score, no, it's not considering. It's also why these scores are not really, they are an help, but all the decision cannot base on these scores because they are incomplete.
Okay. Thank you so much. All the best to your work. Thank you. Bye.
Thank you for these questions. I think I've seen Andrew's hand risen. Do you have question?
Thank you. Thank you, Jan. Can you hear me okay?
Yes.
So I apologize. My connection was a little bit problematic during the talk, so I may have missed it. But I just wanted to ask, obviously you're looking at the wall and you're looking at the features of the wall. I know that there's been a lot of work done on the fluid dynamics within that aneurysm itself. Is that also something that you would consider including within your risk model at some stage? And maybe you want to comment on any issues associated with the flow within the aneurysm as well as the wall. Thank you.
Yes, that's a very important point. We do note that here in Geneva. We did some in the past. We had a collaboration with the London College, in which we investigated the effect of wall shear stress on the organization of endothelial cells. So for some domes, we did emphasis staining for endothelial cells and some inflammatory markers. And we observe different patterns depending of the flow and about the velocity and about the gradient. But we do not do that in routine. There are some teams, I think more particularly to the team of Juan Sebral, who is doing that, and they are really the expert in that.
Thank you.
Thank you. So maybe we have time for one last question, if anyone. Okay. So I guess this is it. Thank you once again for the presentation and for your time. Thank everyone for attendance and nice questions. Yeah. So thank you, and everybody, like, see you next week. Yeah.
Thank
Goodbye.
you. Bye.